Okay, it's honored to be here, and thank you for the opportunity that I can talk today in this class of the short course, International short course conducted by UMM and also the another five universities. Before I start my talk today, I would like to introduce myself first. My name is Henik Rahayu. You can call me Henik. And actually, as Mrs. mentioning that my educational background is nurse. I'm a nurse, and I just graduated from the National Cheng Kung University, Taiwan, for my PhD degree in 2021. And actually, I'm a former of nurse at the International Hospital Surabaya about 15 years ago. And now, currently, I only a school teacher in the nursing department in this university. And for your information, that my major is medical surgical nursing, and actually I'm focusing on the diabetes and also non-communicable disease, particularly in the prevention and the self-management behavior. So maybe I apologize if my talk today is like closely in the behavior, mostly in the behavior rather than for the medication and also the physiotherapy. Hope you can enjoy my talk today. Okay. Today I will talk about what is the post-stroke management. I just a little change my topic, not in the roles, nursing roles itself, but also it's like quite general post-stroke management because I know that you are come from many kind of the healthcare background, like the physiotherapists and also pharmacists. And I take this little change. My topic is the post-stroke management. Okay. Um, as we know that what is the stroke first? SWSO defined the stroke as the rapidly developing clinical sign of focal or global disturbance of cerebral function, which is like in the symptom lasting 24 hours or longer, or leading to death with no apparent cause other than vascular origin. This means that it highlights, it emphasizes that stroke is caused by the vascular in the brain. And I am pretty sure that all of you already know the type, how many types of the stroke itself. There is three types for the major type in the stroke. The first is TIA or transient ischemic attack, which is TIA is a warning or mini stroke. Anything that temporarily blocks blood flow to brain cause TIA. And the blood flow and the TIA symptom last for a short period of time. It's like a temporary stroke. And the second type is a hemorrhagic stroke, which is caused by when a weakened blood vessel structures in our brain. And the last is ischemic stroke, which is the obstructive of the within the blood vessel supplying the blood of the brain. And as you see in the screen there, there's about 87% of the all stroke is come from the ischemic stroke. And let me start from the fact of the stroke. As the World Stroke Organization mentioning about nowadays, if about 12.2 million people is, have stroke per year, and it is about 101 million people worldwide are living with stroke aftermath. And this number is almost double of the last 30 years compared in the 1919 to 2019. And also, they stated that 1 in 4 people will have a stroke in their lifetime, and this number also has increased to about 50% of the last 7 years. And they're also mentioning that each year over 16% of the all stroke occur people in the 15 until to 49 years old age. And there is 47% of all is in men and 53% in women. So it's highlight that stroke is no longer a disease for the elderly right now because most people, not elderly, also have a stroke in the worldwide. Another fact about stroke is like WHO also suggests that in 2019 they estimate that stroke is the second leading cause of the death globally, and this is 6.5 million people die from the stroke annually, and over 142 million years of healthy life is lost each year due to the stroke-related death and disability. And also that as we know in the live in the right side of my project PPT is like you can see that about 89% of the global stroke death and disability combined reside in the low to middle income countries. So it means that actually stroke is can cover all of the countries, not only in the low and middle, but also in the higher income countries. And actually, what is the risk factor of the stroke itself? World Stroke Organization also lists there is 10 leading stroke risk factor in the world. And this is like the first and the second is about the elevated systolic blood pressure in the first one. And the second is about poor diet. So it's like our problem, most problem in the world, especially maybe in urban cities. We can eat many kind of like a moderate, but it's like not healthy. And following by the high body mass index and also the high blood glucose is meant that stroke is also related to the another NCDs such as diabetes and also the hypertension. And actually, the American Stroke Association and also American Heart Association stated that about 80% of all strokes can be prevented. So because the point is here, the key point is here, when we try to prevent the stroke or maybe prevent another stroke for the same person, is using this kind of reducing this risk about the health facility. Lifestyle medication, something like that. And you see this picture here. This is image indicate that there is the most common symptom that occur when based on the position of the damage of the brain. For example, like when the frontal lobe is damaged, usually patient come out with sign like control personality disorder, listening, or part of speech and also muscle movement. And also, for example, like in the parietal lobe, is like focusing on the control speech and sensation, or maybe have difficulty in touch and pressure and something else. Actually, the every stroke is unique, but stroke can do affect people in common ways. Maybe you can see that actually when we can indicate or we can recognize when our patient have some kind of the symptom here. For example, like if they have a paralyzed on the right side of the body, and also like if or maybe paralyzed on the left side of the body, is like the brain damage is of vice versa with the symptom itself. For example, like in the left brain damage, the paralyzed is in the right side, but if the right brain damage, the paralyzed is in the left side, something like that. And also another kind of the symptom we can recognize for our patient. Maybe we can just when a patient have a speech or language problem, slowly or causing behavior style and also memory loss, maybe we can indicate that our patient have left brain damage. And but when patient like arguing about the first vision problems, quick intuitive behavior style, and also memory loss, maybe is right brain damage. Of course, the diagnosis is most used at laboratory and also radiologist examination. And so we pay attention for our patients in the post-stroke. As I'm previously mentioned that I am now focusing on the post-stroke patient, so I didn't talk about what can medication or management in our hospital when as an inpatient or maybe in the outpatient department. And actually, this is the quote about the life after stroke. There is a life and hope after stroke. With time, new routine will become second nature. This means that maybe people, survivor of stroke can be another person, and something like that. Because and also the rehabilitation can build patient strength, capability, and confidence, and it can help patients continue their daily activity despite of the effect of their stroke. Yeah. And I try to highlight about some kind of the common change and in our patient in the post-stroke. It is like divided in the some type. For first is the common physical change after stroke. The first is the physical change that follow a stroke are the result of injury to brain and maybe include one or more effects. And also usually our patient can have a weakness or full life on one on side of the body and fatigue, spasticity or muscle stiffness and also tightness. So it's like in this chapter we can do to support our patient to have this kind of difficulties. For example, like for the to reducing the spasticity, you can have the room or think of motion, passive or active, like or motion or something else. And also we can try to uh, talk to their family or maybe caregivers that they should help the patient to do this kind of the rehabilitation in the physical change. And maybe some patient also maybe has seizures or maybe swallow difficulty or dysphagia and also trouble in the balance, trouble in vision, and also maybe foot drop. So we can try to recognize and we can try to identify what kind of problem that still patient have in this chapter or in this stage. And the next is about the communication, common communication and cognitive change after stroke. Usually our patient have three kind of the biggest communication disturbance, like the aphasia. Aphasia is common communication problem after stroke. There are three types of aphasia. This is about the expressive and non-fluent. People with expressive non-fluent is know that what they want to say, but have trouble to say it. So they cannot find the right word or have trouble getting the words out, or they may use the wrong words or leave out words without knowing it. And the second is about the receptive fluent aphasia, which is patient with receptive fluent aphasia have trouble to understanding words other people speak. They may not understand the order of the words of the relation between the words. And the last is the global aphasia. Is people with the global aphasia may have the unable to speak, like a name object, repeated phrases, or followed comment. They also like have a hard time understanding what others saying. And the second disturbance or problem is in dysarthria. Dysarthria is affect control of the muscle in the face, tongue, and mouth. So people with dysarthria may know exactly what they want to say, but they may speak slowly. Their speech may sound slower, muffled, or close or nasal. And the last is apraxia. Apraxia is of a speech affect the ability to speak. People with apraxia have trouble connecting speech message from their brain to their mouth. So apraxia speech may affect more than the power to speak. It's often affect reading and also writing as well. And apraxia, dysarthria, and also apraxia do not cause a loss of intelligence. It means that although they have difficulty to saying something, to saying a word, saying another kind of the word difficulty, but they did not cause a loss of intelligence. Even though it's difficult for a survivor to speak, it's not because of lack of intelligence. So usually we try to say to our family, to their family that they might to have like understand and maybe be patient when they take care of our patient in this stage. And the third is a memory and cognitive challenges. A stroke survivor may have remember for only short of span of time. For instance, they might remember only two or three steps in the set of the instruction, or the person might forget whether they have taken their medication or eaten of meal. And the second is have trouble absorbing new information. The survivor may need to have things repeated over and over. So we also it's important to emphasize to the family and also caregiver that they should understanding this condition, because be patient is the key to success to taking care of our patients, something like that. And the third is have problem transferring learning from the one setting to another. For example, like in the hospital, the survivor might be able to safely transfer from the wheelchair to bed alone, but in home, the change of setting make the person unable to do the same task. It's like a confusion. This may happen in our patient. And the last is about mix up the detail or of an event. For example, like a stroke survivor might confuse when things happen or who was there. For example, like he or she might think that a family member visit in the morning instead of the evening before because they confused it, something like that. And this is so what we can do when we can communicate or we can accommodate this kind of problem. The first is act with the patient, because when we act the patient, like we can do the demonstration. So how to perform the task and take all the action in the smaller step. And then we also should be clarify the next step and also do the repetition like this. The approach is second time as we were in the first. This means that we can, although we already repeated our instruction, but maybe 20 times repeated 20 is like do it at the first time. And also the second is communicate with the patient. Like when we communicate with the patient, slow it down, like enunciate. It means that we try to slowly to talk and also enunciate one by one, and also come to close, make the eye contact and touch, and also do not visit gentle unless asking, something like that. Because we try, maybe if you can think that we can, how we can communicate to our patients is like we communicate or we in the maybe in the very young people, maybe in the kid, or maybe in the very elder, something like that. And the next is about the common emotional and personality change after stroke. So it's important to give the education to our family, to the patient and also the family, which is maybe our patient can have like a combination emotional personality change, like a post-stroke depression or called PST. Yeah, PST is positive, like maybe have the person sad, anxious, empty mode, depressed mode, loss of interest or something else, and sleeping problem, decreased motivation, and also feeling like hopelessness, and also decrease of energy, fatigue, and also maybe appetite change and thought of death or suicide maybe. So if we find when we five or more of the above symptoms last for 2 or more weeks, it means that a survivor may be having the PSP. And next is about the anxiety. Anxiety also we can try to understand our patient. Maybe they have like anxiety, is high anxiety or something. And the last is about the pseudo-vulgar affect or PBA. PBA is like emotional liability or uncontrolled crying or laughing. Suddenly they will maybe they crying. They suddenly also they maybe have lagging without any causes. So we can try to communicate this kind of problem to not only to the patient but also for the caregiver and also the family, because it's very important to support our patient and the this post of patient, because like this, if you see the quote in the upper here, well, my body and mind were healing. I was learning to be a new person. This means that this maybe is different person when the patient have in the post-stroke stage. And then, so why the rehabilitation is important? We should emphasize to the patient and also to the family that the rehabilitation for the post-stroke patient is very important. The stroke rehabilitation includes sustained and coordinated effort from the large team, including the patient and their family and friends, and also the caregiver and also multidisciplinary team, such as like nurses, physicians, pharmacists, and also physiotherapists. We can work together when also when the family and friends to support our patient in the post-stroke stage. And the communication and coordination among all these team members while working towards achieving the patient goal are key success in the post-stroke rehabilitation and recovery. And you see in the chart here, in the box here, maybe this is kind of the example of the program they include, for example, like maybe rehabilitation of nursing, physical therapy, occupational therapy, speech, language therapy, hearing therapy, or maybe until the support group for uh, the survivor stroke survivor. And what should we be aware of? As we you see in this here, actually, American Association has mentioned that 1 in 4 people survivors will have another stroke in that lifetime. This means that the recurrent stage is like a high risk in our patient. So actually, up to 80% of stroke may be prevented by what? Managing blood pressure, cholesterol, and diabetes, and also making healthy lifestyle choice, taking medication, and it's recommended. This is the three key points that patients should have this kind of change in their life to prevent another stroke next time. And this is the taking step, the taking step to the preventing of the second stroke or maybe another stroke. For example, smoking, physical therapy, alcohol, and also blood pressure, cholesterol, and blood sugar. This is like the key point on self-management of the stroke. And this is as you see in the screen that that 7 life simple acts. I mean, this is like most people in the after school should have this kind of 7 simple lives. The what is that? The first is get active, because the active try to get at least 100 or about 150 minutes per week, or moderate aerobic or exercise, or maybe 75 minutes per week for rigorous exercise for a combination of both. This is like that active is one of 2 highest modification lifestyle, where is like very influent, very important to prevent the stroke, another stroke, and also maybe not. And it also can be used in the normal people to prevent a stroke. And the second is eat better. It is like our patient must emphasize that they have sought the eat better, like eat colorful diet for fruits, vegetable, whole grain, or low-fat dairy products, and also fish and nuts. And try to limit sugary food and also drink, and also fatty and processed meat and salt. So it's like when the 1 and 2 here is the patient can modify it. So maybe another risk can be also can be gained. For example, also the next is a low weight, like maintaining a healthy weight is important for the health of our patient, and also control cholesterol, which is also is like related to the it management. And next is the important one also like our we can see we can emphasize our patient to have the managed blood pressure because uh, as I have mentioned previously, stroke and also diabetes is like very close related. When people blood pressure and also blood sugar higher, it means that the risk of the stroke will be higher. So to kind of the this managing blood pressure and also blood sugar is very important to our patient. And the last is about the non-stop smoking. As I've also found when I have my dissertation research, I try to identify the self-management among diabetes, and I found that most people with diabetes still some people still keep smoking. So if our patient in here in like have the post-stroke still smoke, it's like very dangerous and high risk to be next strokes again. So this is like we try to educate our patients. To, our patients should have like can recognize the risk. Like we use the fast. Fast is like when they have the another um, symptom like face dropping, arm weakness, and speech difficulty, and time to call. It means that this is the sign of treatment or sign on system like a stroke. So we can emphasize that when also the family in home that to recognize this kind of symptom. It is like a emergency. And then we can also use like a mobile health application to help our patient to modify their lifestyle. For example, like we can use the mobile health application for the food journal and also like maybe wearable device that can record the blood pressure, blood sugar, or maybe on heart rate, something else. And as you notice, we said that the mobile has a viable strategy to enhance focus factor control based on the systematic review that I found here. It highlights that using the mobile health was associated with a significant improvement in the glycemic control and also used with significantly higher rates of the smoking cessation. And also the last is about the mobile health impact and control of the hypertension and hyperlipidemia. So this is the evidence that we can also use in this currently situation in the modern era. We can use the mobile health as one of the strategies to help our patients. And also another kind of when we talk about the lifestyle modification, we talk about the self-management for people with stroke. It's, also this paper mentioning that the clinical message from this paper also say that uh, support for the self-management intervention after stroke is growing, but further high quality research required. But it's good. The goal setting and problem solving and the promotion of self-efficacy is like the key point is the self-efficacy are common self-management intervention for stroke survivor. So I also agree that self-efficacy is like the one of the predictors, the higher predictor for the self-management behavior, not only for the stroke patient, but also for the, as I found in my research previously, is self-efficacy also higher related to the self-management among diabetes. And lastly, this is the also can you can go to this paper about the checklist Ph.D. compromise 11 problem area, including the post-stroke patient. This is the global insight into proceeding sequel using the post-stroke checklist. So we can use this checklist to evaluate or to assess our patient in the post-stroke patient and detecting the persistable problem when following stroke. So it's like 11 common problem area here. It's first like secondary prevention, activity, daily living, mobility, spasticity, pain, incontinence, communication mode, cognition, life after stroke, and also family relationship. This is the 11 available checklist that we can use, we can apply to our patients. And the conclusion here is like I conclude that the stroke survivor need also support not only the family member but caregiver, but also healthcare team, which is as our as we as a multidisciplinary team, like from the nurses, physician, and also pharmacists, and also physiotherapist, maybe another like dentist or maybe a dietitian, and also another kind of the support and the community support. And then also they need a facility and self-management education requirements because again I highlight that the self-management education is one of the key points to treating the chronic disease management for the patient, not only for stroke, but also like it can be used in the other chronic disease management such as like diabetes, hypertension, or maybe kidney disease and also heart disease, because it's closely related to the healthy lifestyle modification. And the last message that in this class today, I want to, this message is for us. Your lifestyle choice affect your brain health. This is the quote here is yes. Our lifestyle choice is our brain health in the future. It's never too late to start making healthier choices now. So just get enough sleep, and more, move more, or sit less, and get regular checkup, and also eat healthy. And last is don't smoke or fart. So when we want to get healthy, so take it this kind of the behavior, healthy behavior. Okay, that's all my presentation or my talking today. Maybe I can.
Okay. Okay, thank you very much, Mrs. Henik, PhD, for giving such information and interesting presentation. And now we come to the Q&A session. I'd like to have 3 questions from the participants. So please raise your hand or mention your name and of course your question. Oh, in the chat box, there's already a question, Mrs. Henik, from Nurul Amiratun Najiha. And the question is, does PDA related to cerebellum? What can be done to patients that still have to do heavy work to earn money despite of having partially stroke and have no family to support him or her? Oh, sorry, Mrs. Henik, you're still in mute.
Okay, thank you for the question for Mrs. Nurul. Yes, just to be related to the cerebellum. Yes, sometimes yes, because because as I mentioned in previously, when there's some kind of the brain damage put in left or the right side, also like make emotional dysfunction. You know, when what can be done to the patient with still heavy work to earn money despite of heavy partial stroke? Okay, because as you know, maybe a patient can come back to work again to earn some money. Usually, it depends on their condition. If they didn't ready enough, so if maybe it's it's not good for them to have come back to like happy work, because as you know, for example, like the work is make the brain also work. When people just have the post stroke, like for example, in the very close after discharge from the hospital, maybe they still need to take a rest at home because they still need have the like adaptation. They cannot do uh, just after going back home, just directly to have the heavy work with me. It's like maybe it's high risk to make the another kind of the stroke because the heavy works maybe can make another stress because stress also can make a high blood pressure. It means that it's high risk to have another stroke attack. So I not suggest that, and also in the many reference suggest that there is um, people or survivor which is just come back to the hospital. We cannot allow them to have the heavy work, of course. So because like maybe yeah, it's different. As I mentioned previously, because when patients have the post-stroke condition, they maybe be another person. It means that maybe it cannot do as previously they can do something like that. So if there is have no family or to support him or maybe her, maybe like they live alone, something else, maybe we can just have to forget like maybe we can if the patient have maybe can go to the institution, something like in our in Indonesia maybe have like a the institution for the elderly or institution for the uh, people like social social institution, which is unpaid paid by our government, something like that. Maybe this kind of is answer your question.
Okay, how the answer, Miss Nurul? Is it clear? Okay, she said clearly understood. And Mrs. Henny, there's another question in the chat box. It is from Ega. So the question is, Ega is from Indonesia. First of all, she deeply apologized for the question was explained because she joined in the middle of the course. So the question is, when patients have rehabilitation in stroke, what important things that family must to do if one support them, and how to divide the task between nurse and physiotherapists in the treatment of stroke, especially during rehabilitation.
Okay, thank you. Well, I try to answer this question about when patients have rehabilitation and stroke, and what important thing that family must do if one support them. As I mentioned in the my talk today about we can have the education, patient education is the key point. We can educate not maybe if the it's impossible to educate the patient, we can educate the patient, the family member, because the family member is like a caregiver in their home when patient come discharged from the hospital. So we can teach the family how they can communicate, uh, how they can take care of the patient as like based on their sign and symptom. So it's like, for example, is in my talk today about the like communication, how to slowly communicate, and also how to act, which is like be patient, be patient, be patient. I mean, like because sometimes maybe the burden to take care of the post-stroke patient may be high because the stroke patient is usually is not in the short period time, but maybe in maybe long time. So it's like maybe the family member also have difficulties or also maybe struggle or maybe distress or something. Maybe can also depression. So it's meant like we can support also not only the patient but also the family. And how we divide the task between the nurses and physiotherapists. Yes, actually, we can have different way, of course. Nurses have like many. We can take care of most of the part. I mean, the holistic plan in the patient. But maybe physiotherapists can have the part taking part from like maybe from the muscle rehabilitation, such as like we can ask the patient or family to take them to the rehabilitation in the hospital every week, or maybe as scheduled. For example, every week, every month, or maybe depend on the condition. So like the physiotherapist can help patient like to be like how to sit or how to take a walk again, something like that. But nurses may be taking part in the another kind of the another kind of education. For example, we can focus on how we can emphasize patient to have a modified lifestyle. For example, like the self-management after they going back home to prevent another kind of stroke, as I mentioned previously, something like that.
Okay. How about the answer, Miss Ega? It's clear, I think. Okay. Is there still anyone to ask? Okay, Miss Ega says she clearly understood. Okay, if there's no one to ask, I think that's the end of the Q&A session, and we finally come to the end of the part of this class. And I will thank so much to Mrs. Henik Rahayu, Ph.D. for the remarkable presentation, and to the audience who were very active participation in this session. And hopefully the session will escalate our knowledge. And I think from Mrs. Henik's presentation, other profession can also learn and know about how nurse handle post-stroke patient and learning material to prepare students for international interprofessional collaboration and service later. So please give applause for the speaker and for you all. Online applause. Okay, thank you for Mrs. Henny, and also thank you for everyone. I will close this session with Wassalamualaikum warahmatullahi wabarakatuh. See you in the sixth session. It will be in 8 June. And also we remind to you about re-registration for the student who already registered in this international short course. You can re-register from the link that we already sent in the chat box. So please to re-register. So you you give us the commitment, so you can get the certificate and also transcript from this short course. Okay. Sorry, Mrs. Henny, there is still one question left. Are you still want to answer it? This is from Bruno from Brazil.
Okay.
Okay. Bruno asks about, in general terms, do you think that in healthcare there is a lack of more comprehensive approach to the post-stroke patient who is addicted to tobacco as a joint approach to treatment and addiction from after stroke to minimize the risk of the recurrence?
Okay. Thank you, Bruno. Nice to meet you here. And thank you for the question. Okay, I just want to, it's for the last question, maybe, yeah. Sorry, Miss City. Okay, About the if there is a lack of the more comprehensive approach to the post stroke patient who addict to the tobacco. Yes, actually, one of the another key educational or goal in the post stroke rehabilitation is tobacco use. Also like tobacco cessation. This is one of the biggest, also the biggest problem in the world. How to we can have the program for the tobacco or maybe smoking cessation for not only for the special for the stroke patient, but also for another kind of the disease. As we know, the tobacco is one of the leading cause of the non-communicable diseases like not only the stroke but also like CVD or maybe cardiovascular disease and also another the high risk of the uh, diabetes also. Yes, the program of the smoking cessation when we found our patient has like smoking, we can have the educate our patients like we can make have the patient make the plan to quit smoke. For example, like uh, we can just consult our counseling. We can do the counseling to our patient because we can set the quit within the next 7 days, and we can choose the method like maybe we can have like method of quit quickly or gradually reducing the smoking slowly and then gradually and finally maybe uh, all we can stop it. And also the patient can decide if you need the help from the health provider. We can decide maybe we can do the nicotine replacement or medicine therapy for the this addiction, and also we can prepare the quick day planning, yeah, how to deal with the craving or urge, maybe the like a symptom to have when people with addiction of the tobacco use, we can just like cut and or stop it in the first time, but because it may be harmful for themselves. And the last, when they are ready to quit, so we can support uh, our our patient to quit at the quit or on the quit day, something like that. So yes, uh, tobacco or smoking cessation is program is one of the biggest challenges also in Indonesia, not only in Indonesia, but also I found it is also biggest challenges in the worldwide for the tobacco use.
Okay. To Bruno, is it that a clear answer for you, Bruno? Okay. Bruno say thank you so much, Mrs. Henny.
So,
Again, and once again, I would like to thank you so much for Mrs. Henny Rahayu PhD for the great presentation and also Q&A session. And see you in the next agenda in 8 June. And thank you. Wassalamualaikum warahmatullahi wabarakatuh.